Hi, a very good evening to all of you, and I thank you all for having taken out your precious time to attend this webinar. And this is Dr. Anuradha Ahuja from London. We have a lovely afternoon this day. At the outset, let me thank Dr. Krishna and our CCI team for giving us this opportunity to connect with our lovely audience. I'm very excited to moderate this session on a difficult yet very interesting topic of cardiopulmonary exercise testing, which is not very routinely discussed. To be honest, I think we all try to stay away from this topic during our postgraduate days, at least I did, but I must tell you that I'm getting ever more intrigued now while I'm learning the various aspects of it. Cardiopulmonary exercise testing, as we know, is a dynamic, non-invasive assessment of cardiopulmonary system at rest and during exercise. Initially, this was used in sports and exercise science for fitness thresholds in athletes, but now it has come a long way for diagnostic assessments of patients presenting with dyspnea of unknown origin. It is a useful tool which differentiates various causes of dyspnea from cardiac to respiratory to mitochondrial myopathies to psychological factors or deconditioning. Today, I'm delighted and it's my proud privilege to introduce you all to a renowned pulmonologist from England, Dr. Johnson Sameul, who's the lead for pulmonary physiology, sleep and ventilation in Basildon University Hospital, England. He has developed the cardiopulmonary exercise service in this region, which is used widely by the physician, surgeon, and anesthetist across. Dr. Sameul has graduated from Christian Medical College and Hospital, Vellore, India, with an MBBS and MD degree. He was elected as a Fellow of the Royal College of Physicians, London, in 2008, and as a Fellow of the esteemed Higher Education Academy in 2010. He is an examiner of the Royal College of Physicians and is an honorary clinical senior lecturer of the University College of London. He has been part of working committees of the British Thoracic Society, Royal College of Physicians, London, East of England Multi-Professional Deanery, and the East Anglia Thoracic Society. He has many national and international publications to his credit and has authored chapters in respiratory textbooks. It is my proud privilege to be a part of his team and learning from the masters. Today, he's going to talk us through the various aspects of this topic and make it simpler for us to understand, following which we will have question and answer session for this. Ladies and gentlemen, I bring you Dr. Sameul to discuss cardiopulmonary exercise testing for you all. Dr. Sameul.
Good evening, everybody. Thank you for inviting me to give a talk to the Chess Council of India. I'm delighted to be invited, and thanks to Dr. Anuradha Ahuja, who works with me currently. I'm going to call this talk, What's Wrong With Me, Doctor? And in the process, talk about the diagnosis of unexplained breathlessness. Just a few disclosures which I have to do as mandatory as part of my role. I am a consultant respiratory physician at the Mid and South Essex NHS Foundation Trust. I lead the cardiopulmonary physiology service and the sleep and ventilation service here. I do a lot of education, and I'm the director of medical education across the 3 hospital sites, which are 3 large hospitals. I also help train the undergraduates from 3 medical schools, the University College London, Queen Mary London, and Anglia Ruskin University in Chelmsford, who rotate through our 3 hospital sites, which you can see on the right side. I'm also a senior lecturer at the University College in London, and I work very closely with the pulmonary medicine team at CMC Vellore, which is where I originally trained. I have no declarations of interest as far as industry is concerned. So this is where we work, and just a picture of our overall hospital site with the cardiothoracic center you may see in the far left of the hospital, and London is on the at about 2 o'clock, and you can see the River Thames right through the top. So this is an aerial shot of our hospital site. So the three objectives of what we're going to do in the next 20, maximum 30 minutes is to discuss the differential diagnosis of unexplained breathlessness. I will then introduce a specialized test which some of you, or perhaps even most of you, are familiar with, the cardiopulmonary exercise test, and close with a few scenarios because it's always useful to put this into a clinical context. So let's start off with a scenario to begin with. A 60-year-old male patient comes to your clinic and says he's short of breath. You take an extensive history, and the history is rather unremarkable. There's a family history of heart disease. A chest X-ray and ECG are normal. So people have tried inhalers. Doesn't make much of a difference. The question really is, what would you do in a scenario like this? Perhaps, if it's a general practitioner, you would refer to a cardiologist. You would get an echocardiogram or a coronary angiogram. You may not find anything and referred back saying no cause found on the cardiology side. Come to the chest physician, you and me, we'll do a lung function test, a CT thorax, or maybe even a CT pulmonary angiogram. We may do some reversibility studies, blood tests, and then come to the sort of conclusion that we don't have any obvious respiratory cause. So then the question is, what are the possibilities? There are a number of things which can happen. For example, you can have diastolic dysfunction of the heart if you think cardiology. Patients may be anxious. There may be rare causes, causes like shunts happening either in the lung or in the heart. It may be a functional cause. In the UK and in the Western nations, you can get some benefits. So people may be looking for benefits. You may be obese. There may be a bit of deconditioning. And quite often, there can be a little bit of this and a little bit of that. I think it's important to note that we have all had these interesting problems, since sometimes we just say it's one of those things, give them a few drugs and maybe vitamins and say, go and help out, see if it helps. We do baseline tests, all those tests that I mentioned on top, echo, ECG, stress tests, angiograms, blood, and so on, may not be helpful. It's important to remember that resting tests done in a static state cannot reliably predict exercise performance. And patients are often short of breath when they exercise, and they're often okay when they are at rest. And it's also important to note that the quality of life correlates more with exercise tolerance, whether it be doing things around the house, or going out for a walk in the evening. But more importantly, patients may want to know what is wrong with them. And hence, some specialized tests may be necessary to understand the problem. So looking at a bit more on the differential diagnosis of unexplained breathlessness, this is very clear to most people. It's very easy in retrospect to think about these things. If you look at the respiratory side, you may look at pulmonary vascular disease, for example, or exercise-induced asthma. Obesity often is a reason, because patients have a lot of muscle mass, and that itself can make patients decrease their exercise distance. Diaphragmatic weakness and hyperventilation are some of the other causes. And again, if you look at the right side of the cardiac side of things, those are the things which people do think about. You can have shunts, which often happen. So people have specialized tests. On the respiratory side, we have all those tests with differential VQ scans. You have the standard exercise tests like the 6-minute walk test or the incremental shuttle walk test. There are some challenge tests that can be done. And never forget clinical assessment, because sometimes clinical assessment is very important in picking up things like diaphragmatic weakness or unilateral problems with the chest wall. And cardiac, there are lots of tests we won't go into, but the cardiologists go to town on a number of things that they can do in the test side of things. But I think it's important to note that these tests, the respiratory tests, the cardiac tests, whether they are exercise or not, work in isolation, looking at a particular system. which is where I'm going to introduce this test, which some or most of you may be aware of, the cardiopulmonary exercise test. This test is a composite test, meaning it looks at various systems acting together at the same time while the person exercises. Some of you may have seen this classic cogwheel diagram by Kalman Wasserman from the UCLA in California, who first described at the anaerobic threshold and was one of the pioneers of cardiopulmonary exercise testing. I had the privilege of training with him many years ago. And if you look at this cogwheel, you have, when you talk about the lungs on the extreme right, you inspire the air, it goes through the lungs, goes through the pulmonary circulation, goes through the heart, goes through the peripheral circulation, go through the muscles, and then you have the mitochondria, where you have all the cellular respiration taking place. And then the blood comes back the other way around, and you exhale it in the form of carbon dioxide. At the bottom, you can see the number of things that can alter this transport of oxygen from the environment right up to the mitochondria in the muscle. For example, the lungs, you can increase your tidal volume, take in more deeper breaths, or increase the frequency of breathing. You can increase your respiratory rate. Peripheral pulmonary circulation can be recruited depending on drugs or whether you're actually exercising, whether the vasodilator is there. The heart itself, we know that the stroke volume, the amount of blood the heart pumps out per beat, and the heart rate, which can be increased. And then again, coming to the peripheral circulation, you can dilate the peripheral circulation during exercise. And similarly, you can build up your muscles in various ways. So it is an integrated response, and lots of things can go wrong in lots of places. Maybe some things can go wrong in some places, which combine together to make the patient dysfunctional or may have a problem with breathing. So to understand this, there are a few things we need to know. Some of it may sound very basic, but it's useful to just, skim through this. Firstly, what happens to the muscle? Because at the end of the day, that's where the actual exercise comes, either where you're exercising with your arms or with your legs, often with the legs. What happens in the muscles? What happens to your oxygen consumption in the physiology of it and the carbon dioxide output? The respiratory responses and the cardiovascular responses. So if you think back to your biochemistry days, there are various ways of muscle metabolism. There are three sources of energy. You have the creatine kinase, which is a very poor source, 1 ATP per creatine phosphate. Then you have the anaerobic metabolism, which is again a poorly efficient means of metabolism, where you get 2 ATP per glucose molecule, which comes out. And finally, you have the most efficient form, which is the aerobic mechanisms, where you have 38 ATP molecules per glucose breakdown. So the muscle metabolism, it has got implications because it's ideal for it to continue with aerobic metabolism. That means getting sufficient oxygen into the muscles for the muscles to perform in a very efficient manner. When we can't get the oxygen in, that's when we go down the anaerobic mechanism route, which is not very efficient, and that cannot be continued forever. Then if you look at the oxygen transport, the bars in green are what happens at rest, and the bars in yellow is what happens at exercise. As you can see, the kidney, liver, and brain gets more blood flow during rest, not so much the muscle. But when you exercise, can you see the huge spike of circulation which happens in the muscle? So you can imagine the peripheral vascular disease patient, the patient with heart failure who cannot pump to the peripheries, can have a problem with oxygen transport. So what are the ventilatory patterns? We all know about the dead space where ventilation takes place, but not much of gas exchange. The first thing we do in exercise is we actually increase our respiratory rate. And we can see that very classically in a cardiopulmonary exercise test. You breathe faster. Then you start breathing deeper, starting to take deeper tidal volumes, deeper breaths. And efficient ventilation is when you maximize your tidal volume. And you can take in much more with less frequency, which is actually an inefficient form of the breathing pattern. And the cardiac pump does the same thing. It increases the heart rate, increases the stroke volume, and the cardiac output can go up as far as 5 times the baseline levels when we exercise. So what is this test, the cardiopulmonary exercise test? I'm actually sitting in a CPET lab. It's a simultaneous study of the response of the cardiovascular, respiratory, and muscular systems. And we do it to a known exercise stress, for example, a known load, say 40 watts, 50 watts, 100, 200, even 300 watts, depending on how fit people are. And then we look at the exchange, the measurement of gas exchange at the airway. We'll talk about that in a minute, where we check on ECGs, heart rate, blood pressure, and so on. And this relates to the actual energy which you expend during exercise. So why? As we said before, exercise intolerance cannot be confidently predicted from resting values like FEV1, gas transfer, or ejection fraction. And we all know that system failure often occurs with a combination of systems like the muscle and the heart and the respiratory system under stress. And it's important to state that we don't use cardiopulmonary exercise tests for primary diagnosis, which can be diagnosed by other tests. For example, by doing an echocardiogram to check heart failure, or a pulmonary function test to check pulmonary fibrosis, or COPD. We're talking about the ones where we don't have the answers after doing the standard resting tests. And the reason is because our exercise levels vary. Some people can get fatigued early, while others don't get fatigued early. It depends on their fitness, it depends on their exercise levels, depends on their age, and a number of factors. So this cardiopulmonary exercise test is useful, and we use 3 things. One is in the middle, you have the treadmill, which is the commonest way of people know how to exercise by walking, because we all do that. Then we have the cycle, which is actually a very efficient way of doing things. Most people, even those who have never cycled, can easily learn it. And we perform the most tests in cycle on the cycle ergometer. And finally, we have the arm crank. Arm crank is the one which you use the hands to rotate the things, particularly if you have problems with the hips and so on. So those are the 3 ways that we use it. And we particularly use the treadmill in patients with the indwelling pacemaker for various reasons, because the movement is detected in certain ways. So when we do this test, what do we measure? We measure basically 4 things. Firstly, we measure what's called as the VO2, which is the oxygen consumed by the lungs. Then we measure the VCO2. It's not the same as PCO2. It's the oxygen produced by the lungs, which is measured at the airway, at the mouth. We measure the heart rate, ECG. We do oxygen saturations and blood gases as well. So those are the basic measurements which are made. But by extrapolation, we get a lot of derived values. There are some other values which we look at are what's called as the VO2 max or VO2 peak, which is the maximum oxygen consumption at the termination of the test. The anaerobic threshold is the point of the exercise where you switch over from anaerobic metabolism to anaerobic metabolism. And as I said before, and once you get into anaerobic metabolism, you can't continue the exercise forever, because your utilization of energy is very, very inefficient. It is important to state that people who are long distance runners or marathon runners, they train in such a way that they train to the level which is peak just below their anaerobic threshold, because you can keep that on for long periods of time. Then we measure what's called as the respiratory exchange ratio, which is the ratio of the VCO2 by VO2. So we say it's a good test if they've achieved anaerobic threshold or ventilatory threshold or lactate threshold, whatever you want to call it. So your VCO2 will be higher than the VO2, and the respiratory exchange ratio will be more than 1. Then we look at the oxygen pulse, which is the oxygen consumed per heart rate, which gives us a good indicator of how the heart is functioning. And we also look at the slope of the VE-VCO2, which means the minute ventilation by the carbon dioxide which is produced. So it gives us an idea per ventilation, how much of carbon dioxide comes out, so as to give us an idea whether there's things like VQ mismatch. So there are a number of things which we look at, but these are the standard things which we look at to make some derivations. And then we come up with this plot, which is a 9-panel plot, which is originally designed by Wasserman et al. These gives us an indication of what has actually happened during the exercise. So we do 3 minutes of rest when the person sits still, or sits or does not walk, and take some measurements. Then we do what's called as unloaded cycling for the next 3 minutes, where you cycle like a freewheel without a load, and then you increase the load depending on how much the patient can tolerate. So a very fit person, we may increase it by about 20 or even 25 watts per minute, while a poorly fit patient or a frail patient, we would increase per minute by 5 watts. There are a number of protocols. We won't go into all that, but this is a sort of graph that we would get. And from that, we look at certain graphs to see these are the graphs which tell us if there's cardiovascular limitation or not. And these are the graphs which tell us if there's ventilatory limitation or not. And these are the graphs which tell us if there is VQ mismatch. So we look at 3 big things: overall oxygen consumption, if there's cardiovascular limitation, if there is ventilatory limitation, or VQ mismatch. And obviously, these are also translated as numbers. And with these numbers, we can look to see if what we are talking about is precise. As with all machines, we don't let the computer do the job. We actually double check to make sure what the computer's put down there is the actual value. So why do we do these tests? I told you a bit about the tests. I would say the top reason would be the evaluation of undiagnosed exercise intolerance. You've done the resting test, but you don't have the answer. Some patients with cardiovascular disease, I'll tell you what we do here, patients who are going for transplants and so on. Some patients with respiratory disease, pre-operative evaluation is a very big indication in the UK now, because there are lots of studies which show that resting tests do not predict perioperative and post-operative mortality. And certain subspecialties, for example, the abdominal aortic aneurysms, in the UK, you need all patients to undergo a cardiopulmonary exercise test, upper GI surgery, liver transplants, and cardiothoracic surgery, to name a few. And a few other indications, for example, if you're looking at interventions, things that we use for pulmonary hypertension, some of the studies have come from what are the differences in cardiopulmonary exercise testing pre and post test or treatment. And there are some diagnoses unique to cardiopulmonary exercise test. And I think I put down their early coronary ischemia as the first one, because this is well before you develop many of the other symptoms, because you can see very classic physiological ischemia on the graphs. Pulmonary vascular disease, hyperventilation syndromes, heart failure with normal ejection fraction, and so on and so forth. Deconditioning, muscle disorders, and obviously obesity as well. So what do? We do approximately 225 tests in our center. We've got very good physiologists who do this, and I interpret it with a colleague of mine who's trained and a few of our registrars. So initially, about half of our patients were for preoperative evaluation, but now only 10% because the anesthetists have taken over that. My main referral center is the breathlessness evaluation, patients going for cardiac transplant, and patients with pulmonary hypertension. So what I've done so far is tell you something about cardiopulmonary exercise test. It's not something which we can do, which can talk about or train in just a short session. But the whole idea of this is to give you a flavor of how it can be used. And if people are really interested, CMC Vellore is planning to have a cardiopulmonary exercise course in March of next year. So that's a place to come to. I would expect, if you want to have a detailed understanding how things going on. So coming to a few of the cases that we have, I've called it the good, the bad, and the ugly. When I say good, when patients go back very happy. When I say bad, they're not too pleased, but they're okay. They do know that there is something going on, but they know a reason. And the ugly, you will see as we go there. Okay, so what are the good? That doesn't mean Clint Eastwood is a good man, but there we are. So this is for all of these are our patients, and we use it for teaching purposes here. 40-year-old fit cyclist, and is not able to compete as he feels breathless and out of sorts. So this chap used to do a London to Paris cycling trip sort of every year, and he's not able to do that. So his routine blood tests were normal, lung function tests were normal, heart tests were normal. The question is, what's going on? And he was referred to me. So I can't go through each of this because this would be nice to go through this to tell you what's actually going on. But what we found in this gentleman is what is circled around here. We found that during exercise, his heart rate was not going up. As you can see, it's only 57% of the predicted target heart rate. And he felt a little bit giddy as well towards the end. His blood pressure was sort of coming down as well towards the end of the exercise. So one of the things, he's not on beta blockers, and we felt that he had chronotropic incompetence, and we referred to a cardiologist to see if there's any problems with the right heart. And this is many years ago. I shouldn't be showing this because the patient's name is there, and the cardiologist scribbled on it saying, I have not seen primary chronotropic incompetence. Have you looked at the right heart, and so on and so forth. So they did a right heart catheterization, and they did a tilt table test, and they found that this patient actually did have chronotropic incompetence. And then further, I did not actually speak to the patient when the patient was having the test, but later when we spoke to the patient's got a bit of erectile dysfunction, difficulty in micturition, pupils not dilating properly. And this patient actually had multi-system atrophy. And he was referred to what's called as the Center for Neurology and Neurosurgery in Queen's Square in London. And that's where they made the diagnosis. He went on to have a permanent pacemaker, and he taps the pacemaker when he wants to go faster. So that is this gentleman. He was very happy. This is the second patient. This is a 76-year-old lady, seen by the cardiologist. Angiogram is normal, seen by the chest physician. Full lung function test is normal. So she came to us, and you may or may not see this clearly, but if you look at her values on the other side, her VO2 was well over 100%. You can see it's all in this area, which is what we would predict. All her tests were pretty good. She had a normal cardiopulmonary exercise test, and we did tell her that you can confidently exercise. There was a strong family history of heart disease, so patient was scared of exercising. So this is the patient who had a normal cardiopulmonary exercise test. We told or reassured the patient, you can go ahead and do what you want. So that's the good bits of it. When you have exclusive diagnoses, I've got a lot of other exclusive diagnoses, but I'm just showing you two. But I think one of the weird and wonderful, and one of the mundane that you may also see some patients needing reassurance. The good. What about the bad? This is a 49-year-old lady who presents with shortness of breath for evaluation. Ex-smoker, blood test normal. Again, the standard tests are normal. What would be there? What's going on? We did a cardiopulmonary exercise test, but even before doing the test, we thought we did know the answer, and I've circled it up on top. This is a patient who had obesity and had a BMI of 50. Basically, this patient had a normal heart and normal lungs, normal muscles, but had lots and lots of extra stuff that she had to carry around with herself, and therefore your exercise capacity goes down. This is a study which we did in our center, published in the Thorax in 2012, looking at breathlessness, all causes of breathlessness. We looked just under 70 cases, and we found that patients who were obese, that's a BMI of more than 30, were more than half. And what is more important, that obesity is a sole factor in over half the patients and played a contributory role in almost all patients. That's very important to remember. One of the things what happens to these patients is, because of the excessive weight that they carry, they can reach their exercise capacity early, and all the graphs are shifted upwards, and the efficiency of the exercise decreases. And this is our data. This is another scenario. This is a PE teacher. He coaches football. He's not very old, 35. There's a family history of heart disease. He had all the standard tests. And when he had the exercise echo, he had some T-wave changes in the anterior leads. and he had some sluggish filling of the coronaries, and he's been sick. And the cardiologist told me, Sam, can we do a cardiopulmonary exercise test? I did a cardiopulmonary exercise test on this gentleman. There are lots of things going on here, but I won't have the time to explain it. But the long and short of it was this gentleman had psychogenic dyspnea. So when you have psychogenic dyspnea, when you hyperventilate, when your PCO2 in your blood goes down, you can actually develop T-wave changes on your ECG as you exercise. It is good because I haven't put the exercise ECG. We would ask him to stop hyperventilating and take deep breaths slowly, and the T-waves would come back to normal. So this is a person who had psychogenic dyspnea and had some trouble getting back to work because the school felt that the patient was malingering. So the bad obesity as a cause of shortness of breath, because people don't like to be told that they're obese. Hyperventilation, psychogenic dyspnea are the other reasons. And finally, the ugly. This is a 35-year-old nurse, unable to work due to shortness of breath, can walk only 5 to 6 yards, it's about 10 meters, let's say. She had a short systolic murmur in the ejection systolic murmur in the left sternal border, and was referred to the cardiothoracic surgeons. And the cardiothoracic surgeon came and told me that this patient needs to be seen by me. And so we did a cardiopulmonary exercise test. Her resting tests, including tests of diaphragmatic strength, were all normal. And this lady, we had no objective evidence of cardiovascular limitation, ventilated limitation, VQ mismatch. And talking to her, she can cycle 10 miles every weekend, but finds it difficult to work. And she was being asked to work night shifts. And there were some social issues. So basically, this person was, malingering. And when we did say that there is no abnormality, and in this country, the patients can complain, and we have to give answers on why we explain this to the patient and how we explain to the patient, and did we explain to the patient in a very empathetic manner, and so on and so forth. But still, I had an unpleasant letter. The other reason it's used is for assessment of impairment. For example, if patients are working in certain industries like the coal mining industry, or if they do sandblasting, if they work with asbestos and so on and so forth, and people working on trains and shipyards and dusty environments, they can go for regular checks. This is just a study done a long time ago, which was published in the Blue Journal, American Review of Respiratory Diseases. They looked at 350-ish test patients. And when they initially did resting tests, you can see that about 148 were not impaired, 66 had impaired systems, and 134, they did not know what was going on. And then they did a cardiopulmonary exercise test. They found that people that they were impaired were actually not impaired. They found that who were not impaired were impaired. And most importantly, those who were indeterminate, only 5 remained indeterminate. So you're able to find an answer, which is cardiovascular, airways obstruction, and so on and so forth, by doing an exercise test. So when we said the ugly uses of CPET, you can easily distinguish patients who are malingering or those who want disability benefits. All of you respiratory physicians will know that you can modulate your peak flow as and when, as you feel like doing it, because it's very effort dependent, or your spirometry, because the harder you blow or the better you blow, you can get a better value. So you can't do that on a cardiopulmonary exercise test, because we know if the patient has given up earlier, and we know that if the patient has done a good job, because we know that they have switched from aerobic to anaerobic metabolism. So that's my short presentation. And the take-home message is really, I think it's important to note the breathlessness is caused by a number of systems working together. Secondly, some causes of breathlessness may not be diagnosed by simple tests or resting tests. And you may need to be referred for some specialized test to be done. And I would propose that the cardiopulmonary exercise test can help dissect the relative contributions of the heart, the lungs, and the peripheral system in exercise limitation. And more reassuringly, in some patients, tell them that they are pretty okay. So those are my take-home messages. Thank you for listening. And I'm sure you'll have questions for me when we have the actual session in a week's time. And I'm really hoping you'll bring up some cases for us to discuss. Thank you again for asking me to give this talk. It's been an absolute pleasure.
Thank you, Dr. Sameul, for this comprehensive insight into the cardiopulmonary exercise testing. I'm sure our audience has benefited from this, and this was actually made very easy to understand, especially with the examples that you've quoted. And our audience are now motivated to get this done more frequently for their patients to evaluate any sort of undiagnosed breathlessness in their own patients. There are a few questions that have come across in the chat. Let me just go through them one by one. So there's one sort of non-clinical question though. So there's a, is the CPET going out of the armamentarium in the clinical practice, or is it just remaining a research tool? What do you think, Dr. Sameul, about it?
I think I mentioned it in one of my highlights. The question really is it toys for the boys? You know, something that you like to play with and, you know, have some fun with some various exercise physiology, or do you really have the ace of spades? The answer would be very simple. You know, there are some cases where we don't know the answer. And sometimes what has amazed me is the way the human body works together. And it's no one part works in isolation. And what focuses people often is when you have bits of systems failing to small degrees, which are not significant for that system alone, but contributes to the others. And that's what affects patients. You can have a bit of obesity, you can have a bit of early cardiac coronary ischemia, you have a bit of exercise-induced asthma. All of them put together, you have a patient who can't do very much, doesn't want to take the evening walk, for example. So to answer that question, it's not a research tool. We do very few clinical studies here. There are lots of places where it's used for research on its own. There are lots of areas where they look at high altitude. How does the lung work in high altitudes by getting them to breathe, you know, lower oxygen, and like when you do a flight test and do exercises and such like. But ours is a purely clinical center. And as I said, the vast majority of our cases now are to look at breathlessness of unknown etiology. The other big chunk that we used to do was patients for fitness for surgery, for perioperative fitness. What is important to know is there are lots of societies who want cardiothoracic tests, want cardiopulmonary exercise tests. Just for example, the Vascular Society in the UK want all aortic aneurysms which are not absolutely normal to have the test. Some of you may have seen the ERS, European Respiratory Society, and the ESTS, European Surgical Thoracic, the Thoracic Society guidelines, which came out many years ago. What do you do with a patient who has got a mild decrease in gas transfer, a mild decrease in FEV1? Will you deny that patient thoracic surgery? And I've got a whole talk on fitness for surgery, which we use when we have the courses. And I can tell you there are lots of patients who would benefit with surgery who are not given surgery based on resting tests. But even more sadly for the patients, some patients who are actually high risk who are put to surgery when you actually operate on them thinking the FEV1 and the DLCO is okay. So the answer is it's a very useful clinical test. But as I said, again, it's not for primary diagnosis. You need to look at the indications. And if the indication is right, then the question really is, one of my highlights, what is the question to be answered? Do I want to make a further diagnosis of a patient I know COPD? No, perhaps. But if I don't know the diagnosis, yes.
Yeah, that's a very detailed answer for this. And I'm sure the audience now knows that it is not a research tool, and it is not only for evaluating the athletes, which it started initially as. So we have a lot of other usefulness of this particular test. So Dr. Sameul, do we have any contraindications of doing this test?
Yes, it's the same contraindication that you would have for anybody doing any exercise test. So those of us who have looked at the treadmill test in the old days, nowadays the cardiologists don't use much of the treadmill test, the same contraindication that you'd use. And some of you may be aware of the contraindications for even resting lung function tests. So do you do a FVC in a patient who has had unstable angina or a recent myocardial infarction? So the same things that you would have: a recent myocardial infarction, patients with unstable angina, patients who got problems with the hips. The slight difference from this test as opposed to the old treadmill test for exercise ECG is we push the patient even beyond the target heart rate sometimes, because there are patients who can go well beyond the target heart rate. So we need to be very clear. The other thing to say is it a safe test? The short answer is yes. Because as long as you monitor the patient, there are two things we look at. One, the patient, it can be a symptom-limited test. For the patient can say, I have a chest pain or I'm feeling giddy, and we will stop the test even if there are no physiological changes that we can see on all the monitors that we look at. We look at the cardiac monitors, we look at all the graphs in real time as they exercise. The second thing is the physiologist can stop the test if they find that there are changes when the patient is asymptomatic. We have stopped a number of tests simply because there is cardiac physiological ischemia that we see. We see blood pressure dropping and patient is not yet symptomatic. So we stop the test. So we can stop the test both from symptom limitation and physiological limitation. And we have done well over I think about a few thousand tests since 2008, about 200. I think we've done well over 3,000 tests. We haven't had anybody dying. We've had a few patients having a faint, and sometimes post-test. It's how you do the test as well. So once you exercise, the peripheries dilate, and you let them do some freewheel cycling at the end, or just walk for a little bit, and don't let them just get off the cycle immediately, because there can be pooling of blood. Patients can faint. But as long as the physiologist knows what to do and how to do it, I think it's a very safe test.
So, Dr. Sameul, we all have seen how complicated this test looks when you see the leads being put or patients on a treadmill. Do you think it takes a long time to complete this test, or what is the usual time that a patient takes to complete this test? And how much time do you think does it take you are very expert in this. I know you might just take 5 minutes to interpret the results, but for a beginner, how much time do you envisage that a person would take to interpret the results?
Okay, to do the test, the main thing is the preparation for the test, as in getting the patient hooked up, getting the patient, explaining the test to the patient, because that takes about half an hour at least to get the patient. We give them a patient information sheet well before they come to us. We tell them about what to eat and what not to eat and how to eat, and that's not how to eat, when to eat, and so on and so forth. And then they come here, and then we hook them up to the lines. We make them show them what it is and how it's done. So that takes about half an hour to 40 minutes, half an hour usually. The test, we aim for the test to be between 15 to 17 minutes. So that is 3 minutes of rest and 3 minutes of unloaded cycling. And we evaluate the patient with a load, or rather we give the patient an incremental load depending on how fit they are. So for example, if it's a very elderly, frail person who comes, who is 80 plus, what we would do them in an increment of 5 watts per minute. And if we find, on the other hand, it's a younger patient who is going for a breathlessness test, like those 30-year-olds and 40-year-olds, I would put them at an increment of 15, 20, and sometimes when we test elite athletes, go up to even 30 watts a minute. So you can get in 10 minutes, if you get 10 minutes of exercise with a load, that is sufficient to give you enough information if there is a disability, or in some cases to see what's your peak VO2. For congenital heart disease patients, they look at intervention based on what's your peak VO2. That's another group of patients that we do. So, and then after the test, so we aim for about 15 to 20 minutes, for the 15 minutes for the actual test. And then after the test, it takes about 20 minutes for them to finish. Basically, you want the blood pressure to come down, you want the heart rate to come down like you would expect, and make sure that the patient is okay before they go. So I would say an hour and a half for a patient would be necessary, including preparation. Interpretation is like anything else. When you start riding the cycle or driving a car, it takes some time to start the car and that sort of thing. But with experience, you can do it in about 10 minutes. You would need you'd need to have a certain pattern and a methodology how you do it, and then you assess different tests based on what is the question asked, because how you evaluate, how you look at a test for preoperative fitness is different from how you look at for breathlessness, how we look at for pulmonary hypertension, and so on and so forth. So we have protocol, ways that we analyze these things. And the only thing to say is you can't learn it from a textbook. Well, learn the principles from a textbook, but the only way of actually doing this interpretation is to look at the patients, because there are so many nuances, as you know, Anu, how the test is done. If you don't use the right protocol, you'll get the wrong result. And quite often I have to do tests for patients who have had a test done in some other center, but the physicians feel that this is not a right test, can we repeat it here? So we do that as well. We repeat tests so it depends on what protocol you use, how you use it, and that only comes with exercise. And it will be useful to do it in a center which does it regularly and train there.
Dr. Sameul, I just want to inform you right now, there are 962 people watching this seminar live. So I'm very glad that people are interested and are benefiting by our discussion. So a question, before somebody sends you for a cardiopulmonary exercise test request, what all do you expect them to do beforehand? I mean, do you think they should send you upright, anybody who they feel is an undiagnosed breathlessness, or do you expect them to do some baselines and send it across to them?
Yeah, I would expect some baseline test to be done, because when you say it's unexplained breathlessness, you should have done the usual things. So I get referrals from cardiologists, from general physicians, from respiratory physicians, get from rheumatologists, and so on and so forth. So that's just talking about breathlessness. So you would want them to have done the baseline test. If it's breathlessness, they should have done the echocardiogram, full lung function test, and radiology as well. At least do a CT scan before they come. If there is a question of asthma, because the other question is exercise-induced asthma. Mm-hmm. So, it'll be worthwhile doing simple things like pheno, which you can check to see if there's any eosinophilic inflammation of the airways, which can be present, or you can actually do a reversibility. So some baseline tests would be useful, and because we use it reasonably widely, most physicians know what to do, and they would have actually seen the patients and then send them across for us to evaluate. The surgical patients, on the other hand, they would have done the baseline test, of course. For example, the cardiothoracic patients in our center, if you have a DLCO or gas transfer, which is less than 60%, and if you have an FEV1, which is less than 60%, they refer the patient to us. If it's more than that, they're okay, because if you look at the ERS, ESTS guidelines, anything less than 75%, they say you need to do cardiopulmonary exercise test. And that is true, because we have looked at some of our patients who go for cardiothoracic surgery. It's interesting that some patients, the old guideline would say if you have an FEV1 less than 1.5 liters, you can't do lobectomy on them, and that sort of things. But most of our patients have an FEV1 less than 1.5 liters who go for surgery. The important thing is you need to, one, ask the question correctly and do some of the baseline tests, and that should be fine. I can go on, but I will just restrict to the question that you ask.
I think the cardiothoracic surgeons are also confident once they know that the patient is stable and safe to undergo their surgery once they have the CPEX test, and reassured. So there's a technical question from one of our participants.
Just before you go there, just to say one other point. The other important thing for the surgeon and the anesthetist is the patients which we grade as borderline. So they are not there, but when we look at the patient, of course, there are a lot of guidelines to say what is fitness for surgery by ERS and by the Vascular Society and the Upper GI Society and such like. But when you look at the patient, sometimes, numbers don't always tell the patient, and we put them as borderline, but they don't hit the correct level. And that simply means a red flag to the, not red flag, important note for the anesthetist that the perioperative period, intraoperative period, they have to monitor actively. And that is extremely important for these chaps, and they find it extremely beneficial.
Yeah. So there's a technical question from Dr. Ghosh from West Bengal. He asked that when do you want to stop the test? If the patient's VO2 max is above the predicted value, should we stop the test at that point?
No. Again, what is the question that you're answering is the most important thing. So we do have occasionally some athletes come to us and their VO2, all of you who have done resting tests as well, you know that the FEV1 and the DLCO, you have patients who are 130%, 140%. So if you have an athlete who comes to you who's with a post-illness, there's this, you get a bit deconditioned and they're not able to get back to their fitness. And the other reason is, post-COVID, for example, that COVID has had impact on some of people who've had bad lung disease. So if you say that I'm going to reach the predicted peak VO2 for this gentleman and stop it, then you lose a lot of things, because for a very fit person, that predicted VO2 is bad for that particular person.
Yeah.
And vice versa. So depends on the question to be answered. So we push them till they drop. Either, it's symptom-related stopping, and if you're on a cycle ergometer, you have to do an RPM of between 55 to 65 RPMs per rotations per minute. So if they can't keep up, I am the biological control for my lab. So every year I do a lung function cardiopulmonary exercise test. And, it tells me what my fitness is year on year as I grow older, but also, I know that after a certain level, you can't cycle anymore. So it depends on whether they can keep up to the test, and we push them till as far as they can go. They want to stop or we want to stop. So especially for the breathlessness patients.
True. Dr. Sameul, you just touched on the exercise-induced asthma a bit, but there's a question from the audience. Do you think we can diagnose this particular entity from cardiopulmonary exercise testing?
Absolutely. We don't always use this as a sole method of doing it. There are other tests, as you know, which you can do simple exercise tests post FEV1, but every patient who's breathless to us can have a degree of exercise-induced bronchospasm. So what we do at the end of a breathlessness test, we do a blood gas and we do FEV1s at 0 minutes, 1 minute, 3 minute, 5 minute, 10 minute, and 15 minutes post-test. So we have graphs post-exercise. So that's a very good post-exercise test. We can diagnose it, yes. And we have.
Yeah. There's another question from the safety aspect of this test, is that has there been any health hazards or injuries reported during the cardiopulmonary exercise testing?
As I said, you can get patients with chest pain. We do have patients that we stop the test. Our physiologists are trained and they look at it's like anything else. Our ECG is monitored. You have a 12-lead ECG going around. If you have more than 2 millimeter depression, we stop the test, even if the patient doesn't have symptoms going on. Obviously, the patient has got fainting symptoms. You must also remember that patients can hyperventilate. When you hyperventilate, you can feel a bit giddy. You can feel a bit numbness. So we can see this on the graph. We can look at it by looking at the PCO2 or the end-tidal CO2s and such like. And we can tell them, our physiologist will tell them, breathe slowly. The other thing is dysfunctional breathing, not hyperventilation. So you take deep breaths and slow breaths. And so it sort of, goes up and down. So do we have morbidity? The answer is no. Do you have people who have fainted after the test? Yes. Some elderly patients who, especially ones with peripheral vascular disease, sometimes they vasodilate. Not peripheral, elderly patients on blood pressure tablets, they vasodilate and they can feel a bit faint. We have a cardiac arrest call thing here in case we need to use it. The few times we needed to use it was simple faints, nothing else. We haven't had any patient dying. As I said, we've done more than 3,000 tests here.
Also, that, as you explained, that we've got 3 different ways of doing it, and when we know that one person can't do the treadmill, probably we can go on the hand crank or the cycling ones.
Yeah. So, especially the peripheral vascular ones, they have claudication, as you know, because of peripheral vascular disease, so they can't cycle. So we get them to, and if you have a hip problem, you can't do anything. And there are some patients who've got dislocations of the knee during exercise. So we get them to do the hand crank. And you need to be sure that the values for hand crank will be less than the values for cycle, will be less than the values for walking on the treadmill.
True. There's again one technical question from one of the audiences is asking, what would be the test report you would feel would be there for an exercise-induced pulmonary artery hypertension?
Okay, so for pulmonary artery hypertension, as you know, there'll be, you will have, okay, there are 4 things that we need to look at. One, you will find that their overall exercise capacity, that means the peak VO2 will not be maximal. So they won't reach their normal. So it'll be low. But that can be due to a variety of reasons. So that will be the first thing that you'll notice. The second thing that you'll notice is that you will find that ventilatory, the VQ mismatch. Anu, can you just take the question? I'll be just 1 second. I just have to take this call. I'm on call. Just 1 second.
Yeah, sure.
Hello.
So Dr. Sameul would come in a minute. I think he's got an urgent call from the hospital. He'll be back with us. By the time, I would like to thank everyone and the CCI team, especially for bringing us together here. I'm so happy to be back with my people. I miss you all, and I actually missed all the congregations that you guys all are having and enjoying the academic feast here. So, and also that it's my humble invitation to you all. Anybody who's passing by here, who comes and visits UK, please come and visit me. Have a look at what we are doing. If you're interested in cardiopulmonary exercise testing, you can come around and have a look around in our hospital and see how it is done. Also that we also invite you to give us the difficult cardiopulmonary exercise testing reports if you have and you want some opinion. Dr. Sameul has kindly agreed that in case you have some difficult ones, we can analyze it for you. And in a while, once he's back, I would also let this question put on across to him that if somebody wants to get properly trained in this cardiopulmonary exercise testing, what are the various ways one can get a proper certificate course or trained in analyzing these exercise pulmonary testing. Yeah. So there's another question by Dr. Kulkarni, who's asking if the bendopnea can be an indication for this test. So I think bendopnea can be, once you rule out, mostly bendopnea has been seen, as we know, in heart failure conditions. So if you've ruled out most of the things for it, most of the causes for it, probably, again, if it falls into the undiagnosed entity, then this might give us some clue towards what is the cause of this particular entity. Just bear with us for a moment before we take on more questions. So it is important to know that this particular cardiopulmonary exercise testing is not restricted to people who can do a treadmill test. This was one very important thing that we needed to tell people. People who have problem in walking can do cycling or can do arm cranking. The answers would be got even in those types of testing also. I'm very happy to answer any more questions if there are from the audience. And I'm delighted to see that there are more than 900 participants today in this webinar. Hopefully they have all benefited from it and bring this into their practice. Are there any more questions? Admin, can you let us know if there are any more questions from the audience right now? Oh, all right. So we are very, very thankful to our CCI team for having us here. And on behalf of Dr. Sameul and our team from Basildon Hospital, we are thankful that you guys invited us for having this chat with you. Dr. Sameul is back with us. And
I'm really sorry because that's something which is a home emergency which I had to attend to. Okay, go ahead.
Yeah, home front is the one that you can't probably avoid, isn't it? So there was a question about bendopnea. Somebody's asking if bendopnea can be an indication for the test. I said if there is the cause is not known, mostly it is there in the heart failure. If the cause is not known, we can definitely go for evaluating it. And the question was exercise-induced pulmonary artery hypertension, which you were taking up.
Yeah. So apologies because I had to take that call. Overall the VO2, the peak VO2 will be less. The second thing you may find is patients will, because you will have the primary problem in pulmonary hypertension is BQ mismatch. So you'll be able to see BQ mismatch on the graphs, which show very classical BQ mismatch. And the third thing is that they will be limited early in ventilation as well. So you'll find that the respiratory rate goes up significantly. So you can look at these three things and very easily say that patients will have pulmonary hypertension causing restriction of their problems.
Yeah. Dr. Sameul, there's a question probably everybody want to know right now after listening to this insightful talk by you, that if they want to be trained in cardiopulmonary exercise testing in India or abroad anywhere, do you think there are some formalized courses or certificate courses for it which can help the pulmonologists get trained in this cardiopulmonary exercise testing?
Yes, there are lots of courses, as you know, both in India. I think in India, there's only one course. I think CMC ran it in 2019,
sometimes back.
2018. Yeah. It was a year before the pandemic. I think that was the first one in India, which Bala Mugesh and Barney Thomas, they ran it, and I helped the course. And they're having another one in March this year, or not this year, next year. 1st and 2nd of March, 2024. So if people are interested, they can come there. I'm not sure if there are other courses in India, but there may well be. There are courses in the West. Certainly courses that we run for our trainees here every year for our respiratory trainees. There are other courses which are run by the what's called as ARTP, Association of Respiratory Physicians, Therapists and Physiologists, in the UK. The UCLA in California, they run a very good course. The only thing to say about these courses, it's nice to know the theory. You can go to a course, you will know how it is done, but unless you actually do the tests yourself and then keep doing the tests, it's very difficult. Well, not very difficult. You will not get the hang of it till you actually do the test. To put it in perspective, I first went for a course in 2004 or 5, I think, and then I tried starting to do my own tests here in the Cardiothoracic Center. I was going all over the place. Then I spent about 3 months at UCLA in California with Carlman Wasserman and James Hansen, and that was when everything changed, because the protocols, how it's done, and looking at the nuances. So if you have the opportunity to train in a center who does it regularly, maybe about 6 weeks to 2 months, then if tests are being done regularly, and if you sit and do reporting, then you'll get a good hang of things.
Yeah. Do you suggest any particular book for people to take reference from or read to know more about it?
There is exercise physiology by Wasserman, Janssen, and et al., which is the sort of Bible of cardiopulmonary exercise physiology. It's a good book, and it's written very well. It's quite a big book. There are also smaller books. I think James Hansen has written another book for India in particular, which is published by one of Indian publishers. But I felt that was a bit more physiological rather than practical. Because he showed me the book when he was just publishing it or getting it out. So I think the Wasserman book is very good. There are small what's called as series that you may get. There's one for the University of Washington, which is pretty simple and easy, but that gives you the principles, and it gives you, if you're going to take a multiple choice test, for example, all our registrars I suggest some of these primers that they can look at so that they know what to answer in a multiple choice, but that does not necessarily make you interpret. And I think the best interpretation, if you spend some time in a center which does it, that would be the best thing to do. But read before, either small books, but I would recommend the Wasserman book.
Dr. Sameul, on your behalf, I've taken this liberty to ask them if they have any difficult cardiopulmonary test reports which needs to be analyzed, and they can send it across to us, and then probably we can help them analyze those reports and send across.
Yeah, that should be fine.
Yeah. And the last question is a very, very encouraging question, because that shows us how well this topic has been understood, that it's made some impact to their decision making. So this asks us that thank you for a wonderful learning session. So which are the good brands to set up cardiopulmonary exercise testing in India? So
in India,
I
think the company, we use the wire system here. I don't know. It used to be run by CareFusion, and I can't tell you what it's called in India, but wire is what we use here. We used what's called as PulmoLink, which is a different company earlier. This is the latest ones, which we just changed our system about 4 years ago. Just before the pandemic, that is. So this is an excellent system that we have. They have it, the same wire group. It's called something else in India, but they have the same systems there. And I know the CMC team has got that system in place.
Mm-hmm. Okay.
So if you could contact them, they will be able to tell you exactly who the suppliers are and that sort of thing. And I think there are going to be some demonstrations as well from the Indian systems in their March course.
Yeah. So probably the seminar, which is going to happen in March 24 at CMC Vellore, would be an extension of what we've done today. And I thank you all for listening to it. There are no more questions, Dr. Sameul, here. And if there is some last few words of wisdom that you want to tell us, our audience, about the particular topic that we touched today.
No, just to say, it's simply fascinating once you do cardiopulmonary exercise test to see how there are various things that you can miss otherwise. The other pearl of wisdom is, always look at the patient. Sometimes we are led by tests and we interpret everything by just tests. So the test can mean one thing, but patients can be otherwise pretty okay. So I've learned both those things by doing cardiopulmonary exercise tests. And often when numbers define whether the patient can or cannot do things, you'll be very surprised what patients can do. Because if you have a problem with the lung, your heart may make up a bit and your muscles may make up a bit, and you can overcome some of those disabilities, and you'll be surprised when the systems work together. So the human body is a fascinating piece. Especially designed by the creator, and it's worthwhile studying it, and I've been fascinated.
Thank you, Dr. Sameul. Thank you for agreeing to be part of this webinar. We are highly benefited by this. I'm sure the audience is too. And I am lastly thankful to the CCI team, especially Dr. Krishna, Dr. Atri, who were in touch with me for getting all this flow very smoothly. And thank you to the administrators and to everyone who's involved, and especially to the audience for having an active participation in it. Thank you so much, everyone. We're signing off now.
Thank you.